have to convince the people in the room that we have two major diseases as far as mortality goes. The two accounting for approximately half of all mortality. Cancer is the second leading cause of death to heart disease still, although they're kind of coming together in incidence of death from the diseases. 1 in 3 people in the United States get heart disease over the course of their lifetime. And with improvements in screening and treatment of cancer, we have more and more cancer survivors. And our cancer survivors are not only going to have toxicities from the treatments that we're giving them, but they're going to have incident heart disease. Most of our patients are not worried about heart disease. And actually, we've done a great job treating heart disease in general. So they're not worried about heart disease as much as their cancer, but we need to be worried about heart disease for them. The risk factors for heart disease and cancer overlap. Probably age is very important. Genetics is important. This is a graph showing that the mortality from heart disease and cancer increases over the lifetime. But if in older patients you see that heart disease becomes a major cause of mortality, and actually cancer is less of a cause of mortality in very old patients. So we need to be thinking about that, especially in older patients. There is also an overlap in the demographics of death from the diseases. So if you look at these two figures I pulled offline, one is the heart disease death rates up in the left-hand corner up there, and then in the right lower corner for cancer. You see that they sort of overlap. So you can imagine that people in those areas would have risk factors for both diseases, high cholesterol, diabetes, metabolic syndrome, low physical activity. So many things that we think of, that we know are risk factors for heart disease, are also risk factors for cancer and cancer mortality. And luckily, the mortality for the two diseases is going down. So you see the heart disease mortality for males is going down over time, and for females, and also cancer mortality is coming down. So for us, this represents a lot of survivors for both diseases, and importance of recognizing risk factors for death from both. Being a cancer doctor, I know how many cancer survivors we have, and actually this is wonderful. It's one of the reasons I love practicing oncology and breast cancer, because so many of the people we get to know over a long period of time. But then there is also the problem that there are so many people and to care for. So as we get better methods of detection, better treatments, we're keeping people alive longer, and the number of survivors is going to go up, and the importance of taking care of them, and not only their cancer risk, but their heart disease risk is also important. This is a sort of a very complicated demonstrative figure, and hopefully you'll have access to these online later. You can look at them more. But if you look at this, the major number of cancer survivors are in this older 65 plus group, although we do have young cancer survivors down here with leukemias and testis cancer and Hodgkin's disease, who live a long time to see potentially cardiotoxic effects of the treatments that they get, but also the older people who not only see the cardiotoxic effects of the treatments that we give them, but also incident heart disease and developing cardiovascular risk factors. The major cancers, the number of cancer survivors that we see, most of them are going to be survivors of the cancers that have the highest incidence rates and the lowest death rates in 5 years. So we have a lot of breast cancer survivors, prostate cancer survivors, and colorectal cancer survivors to take care of and monitor over time. This just gives you the number from 2014 to 2024, what's estimated. We're talking about millions of increase in the number of cancer survivors over years, which is a lot of reasons why the Cancer Institute is so interested in helping our patients make sure that they get care and the appropriate monitoring after treatment for cancers. And then also, I can't go without mentioning the fact that 80% of childhood cancers are cured, and a major cause of death in childhood cancer survivors is actually coronary or cardiovascular issues, which may or may not have been related from their cancer treatment. But it's exciting that we're curing many more people, but we still have to think about the side effects over the long term. So when you look in the long term, the risk of cardiovascular death, especially in people who are diagnosed with low-stage disease, is maybe higher than the risk of their cancer. So we need to be thinking of that. So the diseases overlap. So we get an overlap in the patients who are diagnosed and have diagnosed with cancer and have pre-existing cardiovascular disease, and diagnosed with cancer and then get cardiovascular disease, or we recognize them once they come in for medical attention, and then all the cardiotoxic effects of therapy, of which we're recognizing more and more, and Dr. Corey will talk about in the next talk. So from an epidemiologic perspective, what's driving this? We have underlying genetic risk factors and environmental risk factors that lead to cardiovascular disease in cancer survivors, but also health behaviors like tobacco, obesity, sedentary lifestyle, diabetes, and insulin resistance. And those you'll recognize are the same risk factors for some of the cancers that we take care of. When we did a study looking at a database in the CDC ranging over the course of the whole country, about half of our breast cancer survivors in this particular database had pre-existing heart disease at the time of diagnosis. And this is another study that was done that showed that not only do they have pre-existing heart disease at the time of diagnosis in a number of different forms, hypertension, cardiovascular disease, have had angina or an MI, stroke, arterial occlusion, and other illnesses, but then we also recognize in some of them that they get it, or we recognize the diagnoses after they've been diagnosed. So this was a study of 2,500 patients who they interviewed after the course of diagnosis to find out what cardiovascular diseases they were being diagnosed with. So in breast cancer survivors in particular, cardiovascular disease may be the predominant cause, especially in early stage disease, of mortality in people who are over 50. And it's a common contributor to mortality, especially in older survivors. This is a graph from a study that was done by Paetnik et al. And published. You see that especially in the older cancer survivors with early stage disease, we worry about cardiovascular causes of death more than cancer causes of death. That's true of stage 1 and 2 disease because our treatments are getting better and we're curing more people to see problems from other issues. Less so of stage 3 and 4 disease, obviously. So what are the risk factors in newly diagnosed cardiovascular comorbidities, for newly diagnosed cardiovascular morbidities? So those are age, as I mentioned, and that's something we'll take away from this. We need to pay attention to our older cancer survivors who are at increased risk for cancer, and there's a lot of them, and they're at higher risk a lot of the time for cardiovascular mortality. And then higher BMI is a risk factor for both hypertension and cardiovascular disease. Lower education, which is probably a lot of, if we remember that map that I showed you, the education levels might have contributed epidemiologically to the risk factors there. But then also some of the treatments, again, the aromatase inhibitors increase risk of cardiovascular disease, and trastuzumab, which Dr. Corey will cover some more. So there are common risk factors for both diseases. This is actually a study that looked at cardiorespiratory fitness. And you see people who had low cardiorespiratory fitness were actually at higher risk for getting lung cancer and colorectal cancer. Not prostate cancer for some reason. I don't see Mike in the audience, but oh, there he is. But yeah, higher, pardon? I don't know, but possibly. Although we'd have to think about what the risk of testosterone was imposed on cardiovascular disease, but that's a great question. And then the risks for mortality with cardiorespiratory fitness affect both cardiovascular outcome and cancer outcomes. So we'll go back to this original sort of epidemiologic idea of what happens and look at it a little more detail, or adding some factors to it. So you have the genetic and environmental risk factors, and you have the health behavior risk factors. But in fact, the risk factors for cardiovascular disease are more prevalent in cancer survivors. So they have more risk factors for cardiovascular disease than the general population. The FOCUS study was a study of breast, prostate, colorectal, and GYN cancers, and then with this study compared it to a healthy non-cancer population from California. You can see that BMI is actually higher in cancer survivors. They had a lower rate of physical activity. They had higher blood pressure and more incidence of diabetes. So these are patients that we need to be paying attention to for their risk factors. this study went further and actually went and interviewed the patients to see who was talking to their provider about the health promotion and decreasing these risk factors. And actually 1 in 3 of the survivors had not had a conversation with their provider, or the patients didn't have a conversation with their provider to modify those risk factors. I know we're busy, but this is something that our survivorship clinics are going to have to be paying attention to. So to add to the epidemiologic model, we throw in the risk factors of chemotherapy and radiation and surgery, and then also the pathophysiology, looking at those that are causing the cardiomyopathy and increasing risk of cardiovascular diseases that are, or for the cardiovascular diseases that are already in existence, and also perhaps influencing the other risk factors. These are lists of how we as oncologists actually might impact on the heart with vascular conditions, cardiovascular and structural problems that happen as a result of the treatments we give. And cardiac dysfunction is what we think about as heart failure, but it's much more complex. So when we go back to the epidemiologic view, well, we're treating these patients and actually probably maybe adversely affecting some of the risk factors de novo, an increasing risk of heart disease, but also the resultant effect on the cardiovascular system probably has an effect on the health behaviors and might impact the genetics. So now we know that there are actually genes, the carbonyl reductase gene, if there's a mutation in that, that increases the risk of anthracycline-related cardiotoxicity. Well, so if there's genes related there, maybe there's genetic factors that increase risk for cardiovascular toxicity. And then you go back from the chemotherapy and stuff, perhaps influencing the genetic risk that increases the risk of cardiotoxicity. So it can get very complex depending on how you think about it, including the levels of hormones and other things as mentioned by one of our participants. So with regard to cancer survivors, we have to think about taking care of them on multiple levels, preventing diseases, preventing cancer recurrence, monitoring for cancer recurrence and other diseases, intervening when there are things that we see are going on, and then pulling all the people together so that all of the care providers are on the same page. And overall, we have greater success in treating cancer, which is fantastic. Cardiovascular toxicities we know happen, but we need to pay attention to monitoring for them. There are no guidelines for monitoring for cardiotoxicities that are evidence-based. And these may be silent for many years. People can go on for a long time with cardiovascular disease or a low ejection fraction without recognizing it until they kind of maybe have some kind of event happen, and you all of a sudden recognize that, oh, well, by the way, they had a toxicity you didn't know about. There are many guidelines as far as how we need to take care of cancer survivors, and very few of them have evidence, or none of them have evidence-based guidelines as far as cardiovascular monitoring. So they put together what they think is, well, this is what we think should be done as an expert panel. And they have some variation, but most recommend monitoring of blood pressure, fasting lipids, checking an EKG and an echocardiogram, and checking fasting glucose, which should be done in the primary care physician's office, and if patients are going to their primary care, they are getting this done. A lot of times they're only coming to see us because they're worried about their cancer more than they are other things. So we need to think about doing monitoring for cardiovascular risks in these ways. And then the Children's Oncology Group actually recommends monitoring with echocardiograms on varying levels based on history of exposure to anthracyclines. It's a kind of a practical table that I put together based on a lot of different recommendations from different consensus groups. We need some prospective information on how best to take care of these people, though, and what monitoring makes sense. But we're basically left with telling our patients to be healthy, like the American Heart Association does, and move more, watch your cholesterol, stop smoking, make sure your blood pressure is good, try to lose weight or maintain it as best as you can, and make sure your sugar's in a good range. So that's the sum of my talk. Are there questions or comments before Dr. Corey starts? We're good.
We can also take questions.
Yeah?
We can also take questions. We have a panel discussion.
Perfect. Thanks so much.